Good afternoon, everyone. I will be talking about optimal radiotherapy for neuroendocrine tumors. So neuroendocrine carcinoma is a rare histology accounting for less than 2% of all cervical cancers. It comprises of carcinoid, atypical carcinoid, large cell neuroendocrine, and small cell carcinoma. The former two constitute the well-differentiated neuroendocrine neoplasias, whereas large cell and small cell constitute the poorly differentiated neuroendocrine neoplasias. There are no prospective studies available in literature to guide the treatment, and hence it is derived from principles of treatment of neuroendocrine tumors of the lung and of treatment of the more common histologies of cervical cancer. The 5-year outcomes have been reported to be 25 to 47%. So the National Cancer Database was utilized to study the outcomes in patients of cervical cancer and included patients from the year 1998 to 2011. There were 127,000 patients identified, of which 79.5% were squamous histology, 19% were adenocarcinomas, and 1.5% were in neuroendocrine histology. As you can see in this chart, which is the 5-year survival, the neuroendocrine tumors fare much worse than their squamous or adenocarcinoma counterparts, even based on stage. So in this slide, I have represented the patterns of relapse for neuroendocrine tumors on the left, and the more common squamous and adenocarcinomas on the right. You see that the most common pattern of relapse for these tumors is distant. However, for squamous and adeno, the chances of distant metastasis are 16 to 17%, whereas for neuroendocrine, it is as high as 45%. Also, in neuroendocrine tumors, the most common distant metastasis that is seen is lung, followed by liver, and then brain. And pelvic recurrences constitute 13%, and para-aortic constitute 10% of recurrences. So the NCCN 2022 guidelines have given how to manage the tumors. So for early tumors of less than 4 centimeters, primary treatment can be considered as radical hysterectomy with pelvic lymphadenectomy with or without para-aortic sampling, followed by chemotherapy or chemoradiation. The chemotherapy for neuroendocrine tumors is cisplatin and etoposide or carboplatin and etoposide doublet. If the patient is not fit for radical hysterectomy, chemoradiation and brachytherapy can be considered for these early tumors, followed by additional systemic chemotherapy. For locally advanced tumors, the treatment is chemoradiation with systemic chemotherapy, which can be given either in the neoadjuvant setting or in adjuvant setting. The optimal radiation for neuroendocrine tumors is derived from the more common histologies, that is the squamous and adeno, and we consider external radiation to a dose of 45 to 50 gray to the pelvis with para-aortic nodal irradiation in case of para-aortic nodal involvement, followed by brachytherapy to equivalent doses of 80 to 85 gray to the high-risk CTV. So there was a study that was done by utilizing the National Cancer Database from the year 2004 to 2012, and it studied 100 patients who were treated with chemoradiation. And they saw that the patients who were treated with external radiation with brachytherapy had a significantly superior survival of 48.6 months compared to external radiation alone, which was 21 months. Another study of the same database from 2004 to 2014 studied 621 patients, and it showed that brachytherapy showed improvement in overall survival in the locally advanced tumors, that is from stage 2 to stage 4A. There was no benefit seen in FIGO stage 1 or the metastatic stage 4 disease. Coming to chemotherapy sequencing, so I refer back to the previous study, which was done in 100 patients with chemoradiation and studied external radiation versus external radiation with brachytherapy. And the study showed that patients who received neoadjuvant chemotherapy had similar survival as compared to patients who received chemotherapy concurrently with radiation. So I also take the opportunity to speak about our institutional outcomes. So 82 patients were diagnosed at Tata Memorial Hospital from the year 2008 to 2021. Of these, 56 patients were treated with radical intent. The median age at diagnosis was 51 years. Synaptophysin was positive in 81.5% of our patients. Chromogranin was positive in 55% of the patients. CD56 marker was done in 22 out of 56 patients, and it was positive in 77% patients. And neuron-specific enolase was done in only 3 patients, of which 2 were stained positive for the marker. So among these 56 patients, 93% patients received radiation in some form, whether it was with radical intent or in a adjuvant setting. And 91 of our patients also received chemotherapy, either concurrently with radiation or as systemic chemotherapy. Regarding the agents, the most commonly systemic chemotherapy agents that were used were cisplatin and etoposide, followed by carboplatin and etoposide, followed by paclitaxel and carboplatin. So stage 1 had 11 patients, which roughly 20% of the entire cohort. And in this, surgery was the primary treatment, followed by further adjuvant treatment of radiation or chemotherapy. Among the locally advanced tumors from stage 2 to stage 3, which were 80% of our cohort, 90% of these patients received chemoradiation with or without systemic chemotherapy. So at a median follow-up of 21 months, the 5-year survival of our patients was 35%. And when categorized to stage, so early stage tumors had a 5-year survival of 91%, and locally advanced tumors had a 5-year survival of 23.2%. So to summarize, chemoradiation plays an integral component of treatment in neuroendocrine cervical cancer, especially in locally advanced cancers. Optimal radiotherapy includes external radiation along with brachytherapy. Dose de-escalation is not an option at present because we see that with the similar doses, there is a 13% chance of pelvic relapse. And the sequence of chemotherapy has not shown any difference whether we start neoadjuvantly or adjuvantly. However, all this data is retrospective. So probably further prospective studies need to be done to throw more light on this. So, thank you.